Henry Ford, and also came to Iowa in 1980, and I guess you like the climate and everything else. Right?
Absolutely.
Anyway, he's been a tremendous help to us here in neurology over at the University of Iowa, and very pleased to have him here. So
thank you,
please
sir.
welcome.
Thank you. This is kind of higher level of education. You're way up there. I'm just right down here. I think we should put the foot down here, then everybody's going to sit closer. Can you hear me well? Once in one of these lectures, there was a gentleman in the back, so I just was keep saying, "Can you hear me?" He said, "No, louder, louder." So after a while, I said, "Is it any better?" He said, "It's not better, but it's louder." So I tried to cover all bases. I have really no disclosure. Shivapour just explained everything. Now I have to see this slide. I'm just going to come here because I can go with you. So the most common demyelinating disease of central nervous system would be multiple sclerosis. Multiple sclerosis is primarily before age 55, and Charcot was the one that described the classic presentation of multiple sclerosis. There are 2 or 3 other forms, especially the shielders in children, which respond to a steroid and relatively pretty aggressive. 80% of the patients present with relapsing remitting form. About 10% would be primary progressive, and some of those subgroups, they have primary progressive with relapse. That's usually more severe and does not respond to specific medications that we have so far. The history of multiple sclerosis, Charcot described that 150 years ago. I want to be in a position that I can see you and I can see the slides. So, in 1945, the MS Society was formed, and in 1955, all over the world, multiple sclerosis was recognized as one entity. If you have high blood pressure or diabetes, you can go to different countries, they have different names for that. But anywhere you go, you said you have MS, so there's a multiple sclerosis, they should know about that. The gentleman here is Charcot. He is referred to as father of neurology. He is the one that described Lou Gehrig disease, multiple sclerosis, Charcot-Marie Tooth disease, optokinetic misdiagnosis, and so many other neurological conditions. The gentleman sitting right here is Freud. And he is referred to, he was Charcot's student, and he's the father of modern psychiatry. The catcher here is Babinski. You know, when you do the neurological examination, scratch the bottom of the foot, the toe goes up. This is a hysterical patient. And because I have been at university for a long time, my residents keep telling me, even you did not contribute anything to neurology, you're old enough to be in this class. So they counted me right there. I'm the only one who is happy. Now, when we talk about MS and prevalence, every week about 200 patients are diagnosed with multiple sclerosis. You might say that there are too many, but everything is relative. According to a statistic, 40,000 people get killed on the road in this country. Last year was 35,000, this statistic is lower. So it's 40,000 death-related accident on the highways. It comes very close to 1 every 30 minutes. About 400,000 people are dropped dead every year, sudden cardiac arrest. It comes close to 1 every 2 minutes. So if you look at MS, every hour one patient is diagnosed with MS, every 30 minutes a person is killed on the road, and every 2 minutes a person is dropped dead. So the MS prevalence is not really as it has become publicized or people are worried about it. More in female than male. Usually the age of onset is 20 to 50. The youngest patient we diagnosed at university was 8 years old. She presented with optic neuritis, reoccurrence of optic neuritis, MRI abnormal, spinal fluid abnormal, and I told the parents, if it's my child, I want you to go to Mayo's or go to Hopkins or go to Boston. because now there is pediatric multiple sclerosis specialist. There is nothing about it, but parents feels better when you tell them your 8-year-old daughter has MS. They went to Mayo's, they confirmed that she's on treatment. You do not want to diagnose MS patient after age 60 because of all the other related health. It could be diabetes, hypertension, hyperlipidemia, which all cause white matter lesions on the brain. And it's more common in Northern European descent, and I tell you why this idea is there. So the whole world is divided to high prevalence, medium prevalence, and low prevalence. Midwest is medium prevalence, close to 50 patients in 1,000 population, or 1 in 2,000 population. 2.5 million worldwide, 400,000 plus in United States, 4,500 in Iowa, 4,600 MS patients in Iowa. And the cost is keep going up. It's not because of caring for patients, it's because they are not working, they are disabled, and so many other costs associated with that. Now, the epidemiology of MS. We talked about high frequency, low frequency, and mid frequency. Usually there are young couples that mom or dad has MS, and they say, I don't want to have kids. And I say, why not? Because my child might get it. The chance is there, but it's not a very high risk. And the fact is, if those parents move their child by age school, like 7, 8, here it says 15, but preferably by age 10. If they go from high prevalence area to low prevalence, that child will have less chance to have MS. If it's done after age 10, it usually does not make any difference. So it helps them. The other things that helps the parents about having a child, and they're concerned about that. This study is from Canada. 17,000 is a very good number, so we cannot say that, statistically it doesn't make any difference. It makes a difference. Children that were born in November, look at the p-value. They have much less chance to have MS. So I told the young couple, if you want to have kids, the best would be for her to conceive sometimes in February or March. Why? Because in that time, all the trees, everything, grass, flowers, immune system is constantly fighting with allergies. And then there is exposure to sun during the summer months. Vitamin D has become a major factor now, not only in MS. They talk about Parkinson's disease, they talk about Alzheimer's disease, and vitamin D no longer is considered a vitamin, it's a hormone. And the recommendation is that for ladies to have 2,000 units of vitamin D every day. In Iowa, when we check the vitamin D level, usually it's low in the winter. Everybody is cooking, not much sunshine. But in the summer, when you do it, it's normal. Now, the vitamin D, if it's given to a patient with MS, does not really make any difference. But if the MS mom or dad start checking their child to be sure it gets enough sun exposure and enough vitamin D supplement, it might reduce the chance of the child to develop MS. The children that were born in March, because it's backward now, everybody's indoor, not much sun, and the system is just kind of settled down. Infectious, everyone asks, do you know what's causing MS? As of now, no one knows what's really causing MS per se. But there are 3 factors. The infectious agent now has been very much close to Epstein-Barr virus. Mayo has done a lot of work on that, and there is very many good studies that indicates that if the person has been exposed to, most of us have been exposed to it anyway. But if someone was very sick with infectious mono, hospitalized or at home with fever, lymphadenopathy, and they have very high level of antibodies, their chances of developing MS is higher. Then the genetic factors, I'm going to briefly touch on that. The environment. The environment goes back on, if it was a viral illness to begin with, Vikings, it goes back to age of Viking in 600, that they conquered the world in that time in Europe. They believed that they carried the viruses because the first MS patient was diagnosed in that area. Now the other one would be areas that they have less sun exposure, less vitamin D formation, they have more. They did a study in Europe. They got 2 countries, one on the ocean, the other one in mainland. They had the same prevalence of multiple sclerosis. The one that was on the ocean, people that they were on the shore, they had less MS. They were eating more seafood, and it has more nutrition, more vitamin D. The one that was in mainland, the people that they were on the mountain, they had less MS. They had more sun exposure. So this is a recommendation for your patients to be active, proper supplement of vitamin, especially vitamin D, and sun exposure. You have to be very fortunate to be right at the center to get multiple sclerosis. You can have any of the other factors, but you need to have all three of them to have MS. About the genetic prevalence, multiple genes have been related. There are patients that 4 blood-related relatives in 1 or 2 or 3 generations, they have MS. So these genes are identified, and what makes them interesting is during the pregnancy, they become silent. We know that most patients with multiple sclerosis, during the pregnancy, they do well. But still, no specific gene, no gene therapy, no gene manipulation at this time. If mom or dad has MS, they always ask, what about my kids? The good things about MS patients is they are very intelligent and they always read about it. So it was 2 nights ago, I got a call the day after. My patient said they saw some program on one of the local channel in Iowa. A neurologist in Iowa talked about a new medication for multiple sclerosis. And she said, do you know anything about it? I said, new medication? No, I don't know. So why did we talk about it? The doctor was talking about ACTH, adrenocorticotropic hormone. ACTH was first used for MS treatment in 1949, thanks to Dr. Google. I just Googled that. I printed that, I gave it to her. So when I came here to practice medicine, we did not have CAT scan, MRI scan, fancy spinal fluid analysis. You talk to the patient, you get the history, you make a diagnosis. The treatment was ACTH, it's a steroid. But it was somewhat misleading. They keep up with everything. And if you tell them, no, I don't know, or don't worry about it, that's going to backfire. So that was not really a new medication. If mom or dad has MS, the chance of their child would be 10 times higher. We said that in Midwest, 1 in every 2,000 will have MS. The chance of child would be 1 in 200. And I tell them, can you promise me that your child has less than in 1 in 200 to have a car accident, to get involved with the drug, to get a divorce, to have other illnesses? So 1 in 200 is not really a serious chance. If they don't want to have the kids, that's fine. But the chances for having it less. In twin studies, if you get non-identical twin, one has MS, the other one's chance doesn't go higher. In identical twins that we have in our patients group, if the boy, if one gets it, the other one's chance is only 5%. We are talking about identical twins. The chance goes up by 5%. If this girl, the chance goes up by 20% because it's 3 times more common in female. So if your patient is concerned about having kids because of genetic factor, you simply can explain that to them, then that becomes their choice. The viral pathology. So in academic medicine, you publish or you vanish. Somebody had enough time to go through 100,000 blood tests. He identified that 42 of those chart reviewed had multiple sclerosis. And those 42 had higher level of antibody for infectious mono. Again, exposure does not explain that. Being very sick with that increases the chance. Now, what they did is they look at the active MS lesion. You get new enhancing lesion, and if you check the Epstein-Barr IG1A, it was more elevated. 5 years ago, all the focus was on human herpes virus number 6. Now it's shifted to EB, and it seems that there is a good reason to consider that as maybe a contributor to developing multiple sclerosis. pause, which refresh. Now, inflammation, demyelination. This is the blood vessels coughing, all the lymphocyte inflammatory. This is a normal myelin. This is being deteriorated. This is being breaking down to pieces. And Bruce Trapp, who is in Cleveland Clinic, he's not a physician, very, very knowledgeable person in the field of MS, has contributed a lot. He was the one that he explained that the axon without myelin cannot survive. Now, the interesting thing is that thanks to Google, thanks to all the research, we had another physician who came to present to us. This was described by Charcot's student in 1875. So they are joking with Dr. Trapp. I have a lot of respect for him. They tell him, what you really did, you colored what was described before, because this is a fancy computerized picture. It looks very, very nice. The axon, the myelin is broken down, axonal clamp, but all this have been described. Those day and age, there was more respect for physicians or teachers or doctors. Charcot's student did not publish anything until he died. But they all published and complimented what Charcot has been saying. And they are the one that they say this is not only demyelinating disease, the axon is damaged and cells are damaged. And now we keep saying that MS is not a demyelinating disease. It's a whole brain disease. It involves the nerve cells, involves the axon, and involves the myelin. This is control. We all, after age 20, start losing nerve cells. That's the way it is. This is an active MS lesion. It means the cell has deteriorated or died, or myelin has been gone, the axon is dying. And when the axon dies, it's called Wallerian degeneration. It goes back and cell dies. If you get an active MS lesion in square millimeter, they have lost 1,000. This is normal appearing white matter. So when you get an MRI scan and it says 4 lesions, you simply cannot tell the patients, I think you're going to do very well because you have only 4 lesions. But the normal appearing white matter shows the disease process. This is the axonal loss, which is in the normal part of the brain on MRI, and this is in a control. So it's a whole brain disease. This one also explains the mechanism of how the medications are working. So this is the blood vessels. When we say blood-brain barrier, there is not really a new structures. The tight junction of the astrocytes and other cells makes the blood-brain barrier. This guy is a lymphocyte that has been activated. Let's assume it was exposed to EB virus. No, it's an activated cell. It has a memory. It's going to remember. If next time to see Epstein-Barr, it's going to say, hey, do you know what? You have been here before, you don't belong here, and they try to get rid of it. In MS patients, because of genetic problems that they have molecular mimicry. The same lymphocyte is going to look at the myelin, and oligodendrocytes say that, you know what, you're not a good thing to be here, and you have to go. So that's the way that the genetic autoimmune related system is malfunctioning. So this guy, which is activated, it will come out. This is the central nervous system. As a result of reactivation, there are cytokines that they are pro-inflammatory, there are cytokines that they are anti-inflammatory, and that activated lymphocyte will look at the oligo cells or look at the axon and myelin and subsequently cause destruction. The medications that we have for treatment of MS, 3 of them which are beta interferon, Avonex, beta-steron, and Rebif, they have some antiviral property. They help to tighten the junction or blood-brain barrier for these cells not to get out, and somehow they might reduce the inflammatory process that they go on. The Copaxone works differently. We have Th1, Th2, now we have CD4, CD7, CD17, CD76. The autoimmune so-called neuroimmunology is so complex that every 6 months, if you go to a meeting, you learn something new. So Copaxone, what it does, somehow they change the balance between the Th1, which is pro-inflammatory, versus Th2, which is anti-inflammatory. Tysabri, which is fancy medication designer drugs, it works at this level. In other words, does not let the activated white blood cell to cross the blood-brain barrier, come to CNS. As a result of that, then some of these patients get PML, they get brain infection. Because this lymphocyte, they are not only pro-inflammatory, anti-inflammatory, they have so many other functions. There is a group of this lymphocyte, they do the housekeeping. So when they're in the central nervous system, they get rid of debris, bacteria, viruses, tumor cells. So when those blocked by 70% not to get to CNS, if the person is prone to have any kind of viral illness, they're going to get it. Then gelania, what it does, it traps this lymphocyte. Now they are inside. When they come to lymph nodes, to stay there, not to get out. So most medications are working in this process. This is the natural history of multiple sclerosis. It's like Alzheimer's disease. Nobody's going to come on to you and say, you know what, I think in the past 3 months I have developed Alzheimer's disease. Or a patient with Parkinsons, I think I'm getting Parkinsons. They all have had the disease for 2-3 years before they come to you. MS patients don't come to us, except that young lady, 8 years old, lost her vision. MRI abnormal, neuro-ophthalmology abnormal. 3 months later, the other eye. MRI shows new lesions. Spinal fluid is abnormal. But most patients that we get in their adult life, they have had the disease process starting somewhere here. Then this is the first event for them. Relapsing, remitting, the white bars indicates that they have had relapse, the arrows are MRI changes, and eventually they have the disability. All the advocates or anyone who wants to treat MS, they say early diagnosis, early treatment. Why these people don't come to us here? Why don't we get them there? Because we can help them more. That's explained in this slide. So I was telling to one of my patients that we all have this ability, or is God-given, that we can repair. He said, God has nothing to do with it. I said, excuse me, let's start again. So the person here is normal. Let's assume their hands become numb. They go to the doctor, they say you have carpal tunnel syndrome. They do the surgery, you're better. That leaves some scarring in the brain, but still is under the safety margin or cerebral compensation. The same guy will have a vision problem. Goes to the doctor, I think you have new glasses. Fine, they get the new glasses. 3 months later, they don't need the glasses. They are doing fine. They just put it away, they forget about they even had to go to do anything about it. But the third or fourth event, when the healing process exceeds the safety margin, then they come to us. By then, they have 4, 5, 6, 10, 11, 12 MS lesions. So it all goes back to keep getting history. We had one patient a year ago. She works at Boston Children's Hospital. The sister is a faculty at the University of Iowa. She's 43, 44 years old. She was diagnosed with multiple sclerosis. It's kind of older for MS, but again, she was diagnosed and she was placed on natural history of the disease. So the sister asked me, I want you to see her. I said, for what? She has been to Harvard, she was diagnosed. Everything has confirmed that. What do you expect from me? I said, just talk to her. So she came for Christmas holiday vacation. So it comes the sister, the mother, patient, and her husband. So we reviewed the whole thing. I said, you have multiple sclerosis. She said, I told my sister, but she said, I have to come and see you. I said, what just bothers me is you're 46 years old, and you're something in that neighborhood, and you developed MS. It's kind of a little bit old. He said, are you telling me I'm too old? I said, you are for MS. Can you tell me anything might have happened before? Because we hear that. We have had patients that they told me when I had my baby, he's 20 years old now. If I would breastfeed the baby in one side, I could see the face and the baby was feeding. The other side, I couldn't see the face. I had to put my nipple in baby's mouth. That lady had optic neuritis 30 years ago. They said, oh, we had a baby, don't worry about it. About this patient, I keep asking. And eventually, his husband said, do you remember when we got married, you were dragging your foot? And she said, yeah, that was because of the stupid shoes that your mother picked up for me. So they all went shopping, and the mother-in-law picked up the shoe. So I said, fine. How did it go? It was well, but I was not comfortable. I said, did you go for honeymoon? She said, yeah, we went somewhere, West Coast on the beach. I said, were you limping? She said, yeah. I said, were you wearing the shoes that mother-in-law bought? She got upset. She said, I'm not here to hear those things. I said, listen, lady, you most probably had the first attack of multiple sclerosis when you got married. Your leg was weak, you blamed that on the shoes, lasted for a week or 10 days. And now it's 20 years later. The good things is that you have had the disease for 20 years untreated and you're doing so well. The bad things is that it was overlooked and you were not treated earlier, because now she has multiple lesions and black hole or gray hole in the brain. So it all goes back to what Sharko said. Just talk to the patient and get the history. So if we identify the patient, when was the first event before we diagnose them, is very good for them, because we don't compare MS with cancer. In reality, if you have aggressive disease with MS, in 5 years you're in trouble. Somehow, either your vision, your balance, you need a cane. Pancreatic cancer, even Steve Jobs could not fight it. Testicular cancer, Neil Armstrong, with all the performance-enhancing medications, he went around France for 7 times. If MS is aggressive, it's going to get you in 5 years. If the person with MS in 5 years, they're doing well, we say, you know what, you have a good prognosis. If they do well in 10 years, cancer patients, we say you're a cancer survivor. MS patient, we say you have a mild disease. You're going to do well, but you still have to be on your medications. So for that person, having had the disease for 20 years untreated means that she's not going to go to nursing home, she's not going to be in a wheelchair. That's what Sharko said. Talk to your patient, get the history. If there is dissemination in time, my vision was bad, got better, my hand was weak, got better. The sad thing is that now I cannot put too much emphasis on history. Everyone goes online and read, and they give me a perfect picture of multiple sclerosis. So I'm dependent on now examination and confirmation. Then we go to MRI scan or we go to the spinal fluid analysis. When I started practice, we had only this. None of you are as old as I am, so you might not even get what am I talking about. It's called radionuclide brain scan. The guy would come and say, something is wrong, or I'm dragging my foot. We would do that. You would see one spot here. We used to call that hot spot. Is it a brain tumor, a stroke, infection, multiple sclerosis, trauma, AVM? What happened? We didn't know. So patients like that, they would go for biopsy. The biopsy would show there is a loss of edema, the blood vessels are inflamed, there is prevascular coughing, no cancer cell, no infection, no sign of a stroke. Then we said, you have multiple sclerosis. In 1973, CAT scan was introduced. So the person would come with a lesion, same story. It was better than radionuclide, but still, we did not have idea what's going on. So this kind of a patient, they would end up to have biopsy as well. This one was misdiagnosed as astrocytosis. CAT scan became better, became more advanced. We will see multiple lesions. We will say, is it a tumor? Is it metastasis? Is multiple abscess? Or what? Eventually, we had the MRI scan. Has been revolutionized the medicine, but mainly neurology and multiple sclerosis. So the white spot that you see, your demyelinating disease. The black that you see in the middle means cells are destroyed, is replaced with spinal fluid. and they have their own specific characteristic for MS. Another MS lesion in sagittal view, the ring that you see means there was a lesion, is old, the tissue is damaged, there is a spinal fluid there, but the margin is still active. It's usually not a complete ring. Complete ring always goes with metastasis or abscess. We had visual evoked potentials. Patients sit in front of computer, they look at the screen, black and white check size changes, information has to go from your eye to occipital lobe. It should take 100 milliseconds. Because the optic nerve is involved, it becomes longer. So it's called abnormal VEP, visual evoked potential. In the past 10 years, we have ocular coherence tomography. It's a fancy test. It's not that expensive. It measures the thickness of retinal layers. So we all got excited about it. So forget about VEP. But when they compare the VEP, which is about 30 years old, versus this one, which is about 5 years old, they identified that the good old test is still better. Especially if patient has optic neuritis, you get OCT. It shows that the right eye is bad. But VEP will say the left eye is not normal either, so it's subclinical. And if the patient has both eyes involved, it's dissemination in the space. So we do not order much ocular coherence tomography to get more VEP, but ophthalmologists like that, which is fine. MRI scan. This is after injection of contrast, diffuse brain atrophy, port lesion. We call that black hole. This is called gray hole. This is something that you don't want to have too much of. And again, this is the sagittal view. It's called Dawson's finger. Dr. Dawson was a British neuropathologist in 1925. When he did autopsy on MS patient, he said, when I look at the corpus callosum, I see that like my fingers is projecting out. But when MRI came in 1983, 1984, as we learned more about it, they were honest enough to call that Dawson's finger. Otherwise, the guy that who saw it would put his name on it. This is very specific, very pathognomonic for multiple sclerosis. Again, non-complete ring with enhancement, black hole. Now, this is the way that I quiz student. This is all you get. 52-year-old female. Should I choose someone from audience or you volunteer? I don't know, but okay. My name is Shivapour, nice to meet you. This is a 52-year-old lady, that's all you know. I'm the first neurologist that I see her. She came to me, so I talked to her, I got the history, I got MRI scan. That's the MRI scan. The white that you see is lesions. You don't know what, because she has no diagnosis. Again, more lesions, especially this guy is pretty bad. He's right in the palms. It can cause a lot of problems. This is the sagittal. You see the atrophy of the brain. You see damage to the corpus callosum. And again, you see a lot of gray hole, black hole. 52 years old, first neurology that she sees. How would you think she came to me clinically? How did she present clinically when she came to see me? Cognitive deficit. Motor function, do you think she just walked to the office, or she was with a cane, or ambulation problems? So when she came to see me, she said, my mother asked me to come. She had a business in Colorado, and she said, I was not doing well with the business. They said, why don't you come home, then we get you to see this doctor. You're absolutely right. She has some cognitive problems, she couldn't run the business, but otherwise she was okay. Can you imagine this brain? She was okay. So that's the problem with MRI. There are patients that they have 2 or 3 tiny lesions. They have been diagnosed with MS and they put on medication based on MRI. She is on treatment. she has the disease, and she's considered secondary progressive, because when you're questioning her now, she has had problem a long time ago, but it was always either compensated or it was overlooked. But now she's sure in the past year, she has been going downhill. So it's referred to as secondary progressive. If you want to make a diagnosis of MS based on MRI, which you should not, you need to have at least 9 or 10 lesions, more than 5 millimeters, a specific location, thousands fingers. Everyone else, a little bit here, a little bit there. They have had head injury, they have sarcoidosis, they have high blood pressure, high diabetes, high cholesterol, they smoke a lot, that have had prior history of drug abuse. They all make MRI abnormal. So try not to make a diagnosis of MS based on MRI unless it's absolutely classic. Spinal fluid. Spinal fluid is much more important if you really want to make a diagnosis and you are not sure. MS can help you, MRI can only help you 50%, sensitive, specific. Spinal fluid, why the IgG index is 75%? Because it's compared with control. The lab gets your blood, compare that with the control of 200, that's what you get. But when you have the bands, it's 95% sensitive, specific. There is still 2, 3, 4, 5%, but you have to go with exam. And patients now insist, I have MS, because there are 5% that they have normal spinal tap. But the fact is, if you treat a patient for MS, you have 2 spinal taps 6 months apart normal, you're doing the wrong things, because you're setting yourself up for lawsuit. This medication has side effects. You have not proven the diagnosis. You have not confirmed the diagnosis. McDonald criteria, talked about, go by the radiology unit, try to follow that. Again, history, which now can be misleading, examination, positive finding on exam. If the person said, I lost my vision for 2 weeks, and anytime that I'm tired, hot, I get worse, this is just internet. I send them to neuro-ophthalmology or send them to ophthalmology to confirm optic atrophy or optic neuritis. If somebody said that, yes, I was dragging my foot and I think it was MS attack, you should have hyperreflexia in that side, you should have Babinski in that side. If your history is not helpful, exam is not normal, you go with MRI, be very careful about that, and eventually you end up to have a spinal fluid exam. All recommendations are based on early diagnosis, early treatment. Misdiagnosis is common. I have had patients threaten to sue me. They come from California, usually. They have no records, no access to the doctor. You're on Copaxone. How long have you been on it? 5 years. Can I have access to your record? I can't get it. Have you had a spinal tap? Yeah. Was it normal? It was abnormal. I have no records. So what do you want me to do? Renew my prescription. So I cannot do that. I have no confirmation. At least I get MRI scan. I get MRI scan, 2 or 4 small white matter. I said, lady, based on what you are telling me, it's not MS. Are you crazy? I'm going to lose my Social Security. This is a fact. And they can sue you based on hardship that you impose on them. That's the practice of medicine. I tell them, fine, be my guest. You get me all your record or let me have a spinal tap. They never come back. I'm sure they go somewhere else. They convince the doctor, they get their medication, they stay on disability. Don't diagnose MS patient younger than 10, or get involved a pediatric neurologist or MS specialist pediatric. After 50, don't diagnose the patient unless they have had MS. It was misdiagnosed, or it was so mild that they did very well. Because after that age, you're talking more about secondary progressive than prior, relapsing remitting. Treatment is different. You have access to this, you can have a copy of that. I think you have a handout which is supposed to be there. A spinal fluid should not have more than 50 cells. A spinal fluid should not have 200 protein. This is just like you make a diagnosis of lupus when you're really certain, applies to multiple sclerosis. Relapsing remitting, secondary progressive. In the older days when there was no medication, 90% of relapsing remitting, they develop secondary progressive. Treatment is chemotherapy. Primary progressive, and the worst is primary progressive with relapse. Usually no medication helps. We have had like a 40 years old, after 4 years, practically has to go to nursing home because was not able to take care of himself. Differential, the one that we see the most inflammatory one would be lupus, Sjogren, sarcoidosis. We have a few patients with paraneoplastic. The infection, Lyme disease. We have one patient with neurosyphilis. The rest, miscellaneous. We have patients with Hashimoto's thyroiditis, multiple recurrent abnormal MRI scan with enhancement. Some of this disease, including lupus and other, can even have positive spinal tap for MS. We had a young lady diagnosed with MS, on treatment for MS. She came for second opinion. She goes to Coe College, she works for a farmer, works with the horses, and she has picked up so many tick from herself she did not have. These are what you have to do for MS mimics. Coalition vascular disease, Lyme disease, HIV is necessary. So her Lyme disease was positive, spinal fluid and serum. She got IV antibiotic for months with infectious disease. She is fine. She did not have MS. When you make a diagnosis of MS, they cannot buy life insurance, they cannot buy health insurance, they cannot buy disability insurance. They have the history. Their kids get sick, go to doctor, mom had MS, nobody listens to them anymore. You have MS. So you don't want to do that. Clinically isolated syndrome. The person comes to you, say, my vision is bad. Yes, it's proven is optic neuritis. You do MRI scan, either is normal or abnormal. You do a spinal fluids, either normal or abnormal. If your patient has optic neuritis, MRI is normal, spinal fluid is normal, the chance of that person have multiple sclerosis is less than 10% in 10 years. So don't put the diagnosis of MS there because they're screwed. Clinically isolated syndrome. They say, what does that mean? I say, clinically, you're coming to me. Isolated, you had one event. Syndrome, I don't know what the hell is wrong with you. That is syndrome. Carpal tunnel syndrome, arthritis, hypothyroidism, pregnancy, repetitive hand and wrist motion injuries. So at least then I tell them, you know what? I want you to go and buy the insurance. I want you to support yourself. I want your husband to get insurance because you don't know what happened. It's still very rare, but still there is a chance. If your patients come with clinically isolated syndrome, abnormal MRI, abnormal spinal fluid, 50% in 2 years they convert to MS. So you still say CIS, but really encourage them to do as much as they can and treat them. Because treatment for MS is approved for CIS. This is the funniest one that is becoming popular. Fender bender lawsuit, my head hurts. If the person would have the same head injury at home, they would never come to us. But I sleep on Hy-Vee, I felt my head hurts. So they had MRI scan, 5 lesions, 2 enhancing lesions. What the hell is that? Did fall cause that? No. 30 years ago, people that they had accident and they were having tests that proved they have MS, they called that post-traumatic MS. There were so many lawsuits, they took it off the book. So this is called radiographic isolated syndrome. You do a spinal tap on them. If the spinal tap is positive, these patients will have MS. These are silent lesions, but it's unrelated to trauma. So if you say after the accident you go to court of law, there are doctors that they charge $1,000 per hour, expert witness, they come and crucify you. So we find abnormality in MRI scan, the spinal fluid is normal, we would like to repeat that in 6 months. The person has chance to have multiple sclerosis. In my medical opinion, I do not believe it's related to accident. You're entitled to your opinion. Let's get somebody else to say this. But no, this has become a problem. And if you get any radiology report, with all due respect for radiologists, they never tell you what the hell is wrong. It could be this, it could be this, it could be this. And at the end, say clinical correlation. So if I wanted to have all those things and clinical correlation, but they ordered a test. That's the way it is. Pause. These are symptoms associated with multiple sclerosis. I want to have enough time for question and answer. MS fatigue, misleading. The patient looks good, but they are exhausted. If the guy has MS, he used to work 8 hours, he used to come home, put a drywall in the basement, play with the kids, wanted to party all night. He comes from work, he just wants to lie down. If it's the wife, the guys go to work, he come back, she looks good, but she's lying on the couch. What the hell did you do all day? I just didn't feel like it, I'm tired. They don't get it. That's the main reason for most MS patients not to do well. There are medications for that. We start from amantadine, not as effective. Go to Provigil, Nuvigil, Ritalin, and amphetamine. Be sure that they are not abusing that. Depression and rate of suicide, much higher in MS than control. Try not to use tricyclic. It can cause tiredness and constipation. They're already tired and constipated to make it worse. So fine. And then most they have sexual dysfunction. Try not to use some of the SSRI and other medications, Valbuteran, or work with a psychiatrist to be sure that is addressed. Cognitive impairment. MS patients are not Alzheimer's patients. They learn. They cannot multitask. If I have a secretary that I want to get rid of her, I put her in the front. I said, you greet people, answer the phone, take messages, and be sure everybody is happy. She quits. But if you want to, that's the fact. I'm educating people. And if you have someone that you want to keep, he said, fine, I will put you in the back room, no phone, you're on your own. These are all the bills that you have to do. They go through the most complicated billing. So they have trouble multitasking, and it's proven over and over again with neuropsychological testing. This is the natural history of the disease. In 1993, the first medication for MS, beta-seron, was introduced. We had one professor at the university. We applied for the medication. Company was small, could not meet all the demands. So people would submit the name, they put that in a hat, lottery, you get the medicine, you don't take the medication. So these are the patients that this is the disability. These are the patients that they took the medication right away. These are the medication waited 2 years, patients to get it. These are the patients that they never get it until later. So early diagnosis, early treatment. The medications that we have, Avonax, Rebif, beta-seron, they are beta interferon. They can cause flu-like symptoms. They can have injection site reaction. Copaxone is supposed to have least side effect. They will have injection fatigue. They have to take it every day. Natalizumab or Tysabri is the best medication we have. It decreases the cell trafficking from blood vessels to the central nervous system. 1 in 1,000, they can have PML, brain infection. If they are lucky, they die. If they are not lucky, they will have severe disabilities. Gilenya, the new medications oral, has been in the market since September of last year. So far, according to FDA, you can go Gilenya death. It identifies 11 patients have died from heart trouble, and some claim that they are more than that. So they need to be monitored for their heart. They cannot be on heart medication. They can have macular edema, which present like blindness. You have to go to eye doctor to be sure it's not optic neuritis. And then we give them the pulse steroid or here. No one used the stage 1, 2, 3 again. It goes back to the cancer. But you try the so-called first-line medication. We have patients, they do not respond well. Once a month, they come and get IV steroid. We have patients, they don't respond to that. We put them on these medications. What are these medications? When we talk about the antibodies, which is pretty important, beta-seron has about 35%, 30% chance of developing antibody. With Rebif is 15%, Avonax 2 to 3%. When they have antibodies, it crossover and the medication is not as effective. Copaxone is synthetic, does not make antibody. Tysabri makes antibody, does not affect the efficacy. For Gilenya, we do not know about antibody. The agent that we use, we have patients on almost all of them. Pulse steroid, you have just, I was in a meeting, there was a lady, a neuro-oncologist. She said she has been sued 3 times. I said, why? Did you misdiagnose patients? She said it was not even about cancer. She gave patients a steroid and they developed aseptic necrosis, they sued. So you have to tell your patients, when I give you IV steroid or pure steroid, it's not dose dependent. You can have aseptic necrosis. We have had 27 years old, they had hip replacement. We have had 40 years old, they have to have shoulder replacement. As long as you tell them and document, you're okay. Otherwise, you can get sued simply by patients not knowing that they have been on steroid and they have raised. This have been all tried, doesn't work. This is a beautiful movie that you just watch for your own family. It's called Food Inc. The other one is called Fast Food Nation. The director of Fast Food Nation wrote the book about Food Inc. The writer of Fast Food Nation directed the Food Inc. It talks about how the cattle in this country are raised, and they're all on corn. Corn-fed cattle make omega-3, which is pro-inflammatory. Grass-fed cattle make omega-6, which is anti-inflammatory. I don't know how much meat serving you have a week, but it makes a difference. So Fast Food Nation and Food Inc. is just educational for your kids and for yourself and for your patients. I just ask them, please watch this movie. A stem cell, people ask about it all the time. Is autologous, they get your cells, they get your stem cell, and they give it back to you. 4 weeks of hospitalization, 6 to 8% morbidity. Hope Hospital in California, I forgot the name, I think it has something to do with Hope. They had very high mortality, but the best place for a stem cell is Northwestern in Chicago. They have about 22, 23 patients. It's not covered by FDA. It costs $150,000. They want the patients at younger age, because as you get older, your stem cell get older. But again, if somebody is 22 years old, you want to go through trouble with a stem cell. In option, patients always ask about that. EC stands for European Consortium, AC is American Consortium. These are the food in pipeline. One is oral, the other one is sub-Q and IV. They should be out within 2 years. I'd rather stay here and answer questions that you have. That's for a student. So, any questions? Sir. Okay. The
Too late.
natalizumab or Tysabri is the medication which is IV once a month. The best medication that we have. The side effect is 1 in 1,000. If they have not had any exposure to other medications, they can develop brain infection, JC virus brain infection. It is not a treatment of first line. I don't start anyone on natalizumab. We usually do the antibody to JC virus. Before, we were told that if the person has antibody negative to JC virus, they have not developed, so far, they have not developed the infection, but people are converting from negative to positive. So if you have a patient that has positive antibody to JC virus, has been on some kind of chemo before because of any reason, Crohn's disease or whatever, and they have been on natalizumab for more than 2 years, they have, rather than 1 in 1,000, 1% chance to get the brain infection. It's like 11 in 1,000, so make it 1 in 1% easier to remember. If the person has been on all these other medications except for Novantran, which is chemotherapy, you keep them off those treatments for 4 weeks, you put them on Novantran once a month. Sometimes it is plus minus 2 or 3 days. Because most of the brain infection occurred after 2 years of treatment, some they say, let's try to take them off for 6 months or 1 year. There is no rebound on disease activity. Patients is not exposed to any treatment. They might have relapse. It has not proven to reduce their chance of PML. So we have physicians with MS at university. They are on natalizumab. They really should not be on it because it's too strong for them. And their argument is that if I cannot practice medicine, I'd rather be dead. So I talk to the patients, what do you want? Oh no, I want to see my grandchildren. Are you crazy? I already got screwed up with MS. I don't want another bad thing to happen to me. So I really talk to them and write that down in their chart. Knock on wood, we have about 40 patients or so on treatment. We haven't had any problem. The good things about it, you know the compliance. If they don't come, they don't get it. But with a Copaxone, I ask them, do you really take your medicine? Not all the time. And they have 2 months supply in refrigerator. People skip it, especially if they do well. With natalizumab, they have to come to the hospital and get it. Anything else about that? I stopped the medication. Right. When you stop the medication, there is no rebound. In other words, they are not going to just bang, get worse. But on the other hand, they have chance to have an exacerbation. So I talked to them. I said, you know what? If they have relapse on natalizumab, they mean they have aggressive disease. So you have to stop natalizumab. Some people have studied that the effect lasts up to 6 months. But the book will say you don't have to keep them up for 6 months. Keep them up for maybe a month or 2 months. Then the shotgun would be either IV cytoxin or IV novantron. Sir.
Have you any experience with naltrexone, the opioid antagonist, that it seems to be more and more popular in low doses, not just for MS, but for other inflammatory diseases of the peripheral and central nervous system?
Naltrexone LDN was used to treat multiple sclerosis 40 years ago. It did not work. The side effect was seizure. If you go on internet, there are hundreds of testimonials. People swear by that. 1 milligram or 2 milligram in the evening. They just say it makes them feel better, their MS is under control. There is no science behind that. There is no double-blind study behind that. We have doctors with MS that they take it. They say it helps. So if my patients wants that, it's done through the specialty pharmacy. We just call them, they get it, but simply we say, we don't believe it's going to cause MS problem. It's going to help you with MS. And if you want to take it, that's your personal choice.
Why do you think that there are no randomized clinical trials to try to, I mean, this is a very cheap medication and the doses are very, very low. So
they tried that 30 years ago, it didn't work.
But nothing has tried recently to do that.
No. And we had one physician who has MS, he wanted even to give his own money to someone to help. Pharmaceutical company do not want to contribute because then you have to compare that with their medicine. If you say it's better, you're a loser. Why do you have to pay 5,000 versus pay 150? So nobody else can with the money to get 100 people double blind. Any other question? Thank you very much. I appreciate that.